students. Basically, welcome you, sir, for these classes. And with we have Dr. Aniruddha Datto, who will be presenting the key sessions as well as the presentations. He is a consultant nephrologist working in the Kolkata Kidney Institute and is a resident also in the IPGM here. So without wasting time, we should start the discussion. Over to you, Dr. Tathagato. You seek the permission of your teacher and start the presentation.
Thank you, sir. Sir, should I start?
Please do, and all the very best.
Thank you, sir. Good evening, respected teachers. Today, I am going to present a case of Mr. R. Ghosh, a 37 years old male, religion Hindu, who is a resident of Nabogram, Murshidabad, West Bengal. Date of admission was 28 October 2024 and date of examination was 28/11/24. The informant was he himself and he seemed reliable. Chief complaints: decreased urine output and bipedal and facial swelling for 3 weeks and rising serum creatinine for 18 days. History of present illness: I would like to date back my history to December 2022 when the patient was 35 years old. At that time, he started having generalized weakness, headache, nausea, and loss of appetite. He also had passage of foamy urine for a few months before that, for which no medical opinion was sought. There was no history of any recent episodes of fever, vomiting, any visual disturbances, or any behavioral change. No history of any facial, abdominal, or pedal swelling or burning sensation during passage of urine, or decreased urine output, high colored or reddish urine, hair loss, oral ulcer, rashes, or joint pain was there. There was no history of intake of any painkiller or any alternative medications. There was no history of frequency, recurrent burning micturition in childhood. Within a week of having these symptoms, he went to a local doctor and he was detected to have very high blood pressure. He was advised some blood tests, and after that he was told that he had high creatinine and was referred to nephrologist. He came to our institute in January 2023, where after some imaging of his abdomen, he was told that his both kidneys were small and he was advised to initiate dialysis and also counsel for kidney transplant. His dialysis was initiated subsequently via a line on right side of his neck. He continued taking 3 per week hemodialysis, and in due course, a right-sided permacath was inserted, which was later removed once his left forearm fistula started working. Initially, he had good urine output for around 1 year, but after December 23, it started to decrease and it became minimal over next 8 months. In January 2024, he had severe abdominal pain for which he underwent ultrasound and was diagnosed with appendicitis. He underwent appendectomy in a local hospital and postoperative course was uneventful and was discharged, although he was transfused 3 units of PRBC during this period. He continued his dialysis with injections for increasing his hemoglobin levels. His transplant workup was finished by October 2024 and he was admitted here on 28 October 2024. He underwent ABO-compatible live unrelated renal allograft transplantation on 5th November 2024. The donor was his mother-in-law, who was 48 years of age, non-diabetic, normotensive, and hypothyroid, controlled well on medications at the time of donation. Blood group of the patient was A positive and his mother-in-law was O positive. Preoperatively, he remembers that he was started on tacrolimus 3 mg twice daily and MMF 500 mg thrice daily, 2 days prior to the surgery. He was given 1 session of hemodialysis via the fistula and a line was placed on the right side of his neck. He does not remember about the induction agent. After the surgery, he remembers that he had good urine output for the first 3 days and his creatinine came down serially to a nadir of 1.6 mg per dl. After 3 days, His urine output started to decrease, and pedal and facial swelling appeared subsequently. He remembered that his blood level and platelet were low. He remembers some blood test was sent outside and his medication was also readjusted. He was given few yellow infusions, saline and injections, but his urine output remained low. He developed respiratory distress since post-operative day 5. No chest pain, palpitation, burning micturition, frothiness or reddish discoloration in his urine was present. He had no fever, cough, hemoptysis, altered sensorium, increased drain output, pain or redness or discharge from the site of surgery during this time. He underwent one session of hemodialysis on postoperative day 6 with PRBC and platelets. His urinary catheter was removed on day 4 postoperative day, and the drain was also removed by first week. His creatinine was 3.1 by day 7, as he remembers. His creatinine continued to increase and urine output remained low. On postoperative day 12, he underwent kidney biopsy and was put on some special form of dialysis with small glass bottle infusions. He underwent 5 sessions of special dialysis and 4 sessions of hemodialysis till the time of examination. His urine output gradually started to improve and his creatinine also fell down to 1.7. His current urine output is 2 liters per day. Coming to birth history, sir. He was born out of a non-consanguineous marriage. Mother was a non-booked case and it was a term vaginal delivery, non-institutional. Exact birth weight, he can't remember. Childhood history, there was no history of any developmental delay, no history of any recurrent UTI or any surgery in the childhood. Scholastic performance was average. Personal history, he is a non-vegetarian and takes average Bengali diet. Non-smoker, no history of alcohol intake, no history of any high-risk behavior, normal bowel movements at present. Urine output at around 2 liters per day. No known allergies. Family history, he resides with his mother, wife, and only child. No family history of renal disease or any other chronic disease in any family member. Father died in 2011 due to some heart-related illness. Socioeconomic history, he is a central government employee, the only earning member of the family with a monthly income of around 30,000 per month. They live in a pakka house with 3 rooms and bathroom. Immunization history, childhood vaccination was age appropriate. Before transplant, all 4 doses of hepatitis B, pneumococcal and influenza vaccination was done. Should I tell the summary, sir?
Yeah, go ahead. Tell the summary.
Okay, sir. 37-year-old Hindu male, probable native kidney disease being chronic glomerulonephritis, access being left-sided AV fistula in forearm, hemodialysis vintage of around 2 years, history of appendectomy, blood transfusion within 1 year, underwent ABO-compatible live unrelated renal transplantation with mother-in-law as the donor on 5th November 2024 with graft function, low platelet and hemoglobin in the postoperative period. Creatinine at 1 week was 3.1. He was started on hemodialysis with PRBC and platelet support since postoperative day 6. Kidney biopsy was done and he was further managed with special forms of dialysis and IV infusions. His creatinine and urine output gradually improved.
Okay, so based on your history, what is your provisional diagnosis?
My provisional diagnosis will be, sir, it will be a case of early acute allograft dysfunction in an ABO-compatible live unrelated renal allograft recipient, donor being his mother-in-law, date of transplant on 5th November 2024, probable native kidney disease being chronic glomerulonephritis with hypertension, anemia, and history of blood transfusion. And the likely cause for this allograft dysfunction, my first differential will be, sir, acute rejection, likely antibody mediated, and second will be post-transplant thrombotic microangiopathy. I would also like to rule out CNI toxicity and any possibility of recurrence of native disease.
Okay. So now can you finish off the examination and then we can we go to the case.
General examination. Patient is alert, conscious, cooperative, and oriented. Decubitus of choice is lying in supine position. Decubitus of choice. Build is average. Height is 165 centimeter. Weight 52 kg. BMI 19.1 kilogram per meter square. Skin and nails are normal. A left forearm fistula is present, likely radiocephalic, which is having good fill and bruit. Pallor positive. Edema is present up to ankle. Bilateral. Cyanosis, clubbing, jaundice, or palpable lymph nodes are not present. Temperature normal. Pulse is 82 per minute, regular, good volume. Felt in all 4 limbs. Arterial wall not thickened. No radioradial or radiofemoral delay. Blood pressure is 154 by 96 millimeter of mercury, measured by auscultatory method in right upper limb in supine position. Neck veins are not engorged. In systemic examination, in CNS, patient was alert, conscious, cooperative. Cranial nerves were within normal limit. Power of both upper and lower limb was 5 by 5. Hip tendon reflex was normal. Plantar bilateral flexor. There was no tremor, and the sensory system was normal. In CVS, there was no bulging or deformities in inspection. Apex beat was filled in the left fifth intercostal space in the mid clavicular line. No heave or thrills. S1, S2 was normal in auscultation. No adventitious sound. Respiratory system, upper respiratory tract was normal. Trachea was in midline. Bilateral equal movement in chest with respiration. Breath sounds were normal vesicular breath sounds over all the areas and no added sounds. On abdomen, inspection, all quadrants moving equally with respiration. Dressing over right iliac fossa, and upon removal of dressing, there are multiple stitches present over the area in an oblique fashion without any redness or discharge. There was soft, non-tender. Abdomen was soft and non-tender on palpation. No palpable organomegaly. The margin of graft kidney was ill-defined. Tenderness was absent and feel was also absent. There was no shifting dullness or fluid thrill. On auscultation, IPS was 3 to 4 per minute. No bruit heard over the graft site. Urine dipstick showed protein 1+ and blood absent.
So any what's the final diagnosis that you make after examination? Is it the same or anything different?
Yes, sir. I think it will be early acute allograft dysfunction, and in a case of ABO-compatible live unrelated renal transplant. And the likely cause of the allograft dysfunction, I still would like to keep acute rejection as my first differential, and second can be post-transplant TMA. And I would like to rule out CNI toxicity and recurrence also.
Okay. Anyway, good presentation. So let's start off from the very beginning. You said that this gentleman in the year 2022 had drop in urine output and edema and was found to have advanced renal failure, very high blood pressures.
Yes,
and so what do you think he could have had? You said chronic glomerulonephritis as the possible etiology of his kidney disease.
yes, sir.
Which type of glomerular disease do you think he could have had? I mean, this is all hypothetical because we don't have a biopsy. So what are the possibilities?
Sir, in our population, in these cases, we find IgA nephropathy, sir. IgA nephropathy can be a possibility.
Okay, so that's one. What else?
IgA nephropathy. So it can be reflux, sir. Reflux nephropathy can present like this also.
Okay, what else?
Sir, FSGS can present like this, but the presentation is not that much matching, sir, with FSGS kind of presentation. FSGS or MP.
Why do
Sir,
you say it is not matching with FSGS?
Sir, FSGS usually have some acute like presentation. It's not. This disease was like not present for so long, he couldn't understand that much. But FSGS, there will be acute onset edema, and he will complain of that foamy urine, and urine output can drop. That kind of presentation is much more commoner with FSGS. For that proteinuria, he didn't seek any medical advice.
But do you think the IgA nephropathy, the progression, I mean, the disease fits in with IgA? I mean, see, he was, he was found to have high blood pressures. He had weakness, nausea, loss of appetite, foamy urine, and within a week's time, his blood pressure was bound to be high, and found on his creatinine on investigation was found to be very high. And he was started on dialysis within 2 months of his illness or 1 month of his illness. IgA would be, does it progress that rapidly, or is it?
Usually it doesn't progress that rapidly, but sir, maybe the disease was present before that. He couldn't appreciate it, and when he came to know about it,
So what's the usual rate of progression in IgA nephropathy? How quickly or how fast does it progress?
It takes around years to progress 2 years at
2 decades.
Decades.
To progress to end-stage kidney disease, to advanced renal failure. So in this individual, I mean, he could be IgA, we don't know. I mean, he is 34 years at the time when he had this, 35 years at the time when he presented. But I would still think that he may have had some sort of focus FSGS, which may have progressed more rapidly. Blood pressure is usually much higher in a patient with FSGS. So that could be, I would keep that as number one. And IgA, of course, is the commonest variety of glomerular disease. So therefore, you could keep it as number two, unless he has had a crescentic form of IgA, which is very rare, less than 5% of the patients. So he was started on dialysis, and you said initially he was put on a right-sided IJV, which was changed to a permacath. And, so how long does a permacath, how long can we keep a permacath?
So permacath can stay, I mean, our experience, it can stay up to more than 2 years it can stay. But usual lifespan is 6 months to 1 year. 1 year, at around 1 year period, it starts having some dysfunction. 6 months to 1 year, that I'll say so.
Okay. So this fellow, he was started on dialysis 3 times a week, you said. How do we decide when a patient comes to you for the first time with advanced renal failure, how frequently should we dialyze a patient? Patients always tell you that, sir, don't put me on twice a week, put me on once a week. So how do you as a doctor decide that the patient requires to be dialyzed 3 times a week, or does it require lesser dialysis?
So the starting of dialysis actually depends on development of uremic symptoms or refractory volume overload or metabolic abnormalities that are not amenable to managed by medical therapy.
Absolutely correct.
So when we start the dialysis, we have to think about how much the clearance, if usually the studies have shown that MHD 3 per week is required to achieve a KT by V of at least 1.4. But now there is a concept of getting of incremental HD, by which we can see there is less of dialysis shock. When we are starting a dialysis, it's an impact to the patient regarding physically, emotionally, and other aspects also.
More importantly, something else, which is why are people proposing this incremental dialysis? There's something extremely important besides emotion.
Residual renal
Exactly. So the residual renal function can be better preserved if with lesser dialysis. Yes. And a patient whose urine output, you said, was almost 1 liter to start with. Yes, was it right? So you said that he had a urine output at the time when he was initiated on dialysis was almost close to 1 liter. Yes. So therefore, he had a significant amount of residual renal function. Generally, what is the eGFR at which you start dialysis? What is the recommendation as of now?
It's a 10. So eGFR less, we can start in more if the symptoms or those things are there, any compulsory indications there, but EGFR is less than 10, we can start dialysis.
So which study was there which looked at starting dialysis, whether it's starting early or starting late? Which study looked at it, whether it's beneficial to start early or whether there's no benefit in starting early?
So,
Was that-
ideal study.
Yes. So there was an ideal study, and there were several others besides that, which looked at the time of starting dialysis, and the EGFR. Generally, most societies have recommended that your GFR around 6 to 7 is when you initiate the patient on dialysis. And now people have looked at this thing of preserving the residual renal function. It has been seen that it is better preserved with peritoneal dialysis as compared to hemodialysis. But there are new dialyzers which are now available and that can also preserve the RR. So why is preservation of residual renal function important?
So preservation of residual renal flow is actually associated with more middle molecular clearance that is usually not achievable by the dialyzer always. And if the middle molecular clearance is more, we can have CV mortality rate can be brought down, and we can also have less hypervolemia if the RRF is functioning. And so patient's diet and the restrictions will be a bit be more convenient to the patient.
What else?
There will be less hyperphosphatemia, sir. Other electrolyte-based, and
Very
there
good.
will be hyperkalemia. And
So renal bone disease.
renal bone disease will also be improved.
What else?
So beta 2 microglobulin clearance, middle molecular clearance will be.
Okay. What
CV
about anemia?
benefit? CV benefit is
Anemia?
yes, sir. Anemia will be more improved in patients with preserved RRF.
So, and nutrition. And so they have found that you will be able to preserve these things better. There'll be less chances, less anemia requirement, less requirement of erythropoietin, better, less renal osteodystrophy because of the phosphorus clearances being maintained. So those are better with if you have a residual function. Okay. And therefore you can start with 2 and then increase if your GFR drops further to maybe 3 times a week so that you achieve adequate clearances. Okay. How do we decide that your dialysis is adequate or not? What are when you as a nephrologist, when you go around and look at your patient, how do you decide besides looking at the parameters, and what else do you check?
Sir, one thing of dialysis adequacy is we have to look at the patient holistically. Not only the one thing is KT by V, the urea reduction ratio that we can check, and if adequate KT by V is achieved by the dialysis. And another thing is we'll have to look at the other parameters like we have to see if the anemia of the patient is corrected, the hyperphosphatemia is corrected, there is any MBD component or not, how is the LVH or left ventricular function is working, and how overall the patient is.
The first thing you need to ask the patient is how is he doing?
How is he doing?
Is he feeling well? Is he feeling well or not? Is he eating well or not? Is he eating sufficiently the things that you have suggested? So that is your first clinical impression that you should make. Then you do a physical examination and then you look at his lab values and decide whether this dialysis is adequate or not. Okay. Now you said that he received 3 units of blood transfusion.
Yes, sir.
When he had this appendicitis and he was operated upon. So why were you emphasizing on this blood transfusion business?
So the blood transfusion history actually indicates the thing, probably the anemia in that period. There can be always a blood loss during that anemia, that operation period, and the anemia was not properly maybe managed during that time. And another thing is sensitization, sir. As
I think the important thing in this patient is that if you're going in for a transplant, you try and avoid transfusions as far as possible, unless there is an emergency sort of situation. And if you have to transfuse blood, then what precautions would you take as a nephrologist in a patient who is likely to go for a transplant?
We can give the leukodepleted blood or leukofilter. We can give blood through leukofilters.
Absolutely, leukodepleted blood. And some people, they start the small doses of immunosuppression a few days prior to transfusion in order to sort of prevent any body formation as a result of the blood transfusion. Okay. You were also mentioning about the dialysis vintage. You mentioned that he has been on dialysis almost 2 years before he underwent a transplant. How is that important?
Sir, a patient of long dialysis vintage, they usually have more CV they have more morbidity and mortality associated. So post-transplant expected survival, that we have to take into account, and the other comorbidities may also be high regarding like anemia, CV morbidity, hyperparathyroidism, and
that is fine.
arterial stiffness.
Is there any impact on the graft outcome? Does
Yes,
dialysis vintage have anything to do with the graft outcome?
yes, sir. One thing is that the arteries calcification will be more, so the anastomosis can be difficult to do, and that's why graft function can be impaired. And also, more exposure to long vintage can give rise to more DSA or sensitization, and
That's the important part. So, if you have a long vintage, the likelihood of the patient developing some donor-specific some antibodies, which are likely to have an impact on the outcome of the graft. So that is, so what is have people looked at the duration and said that any dialysis which is happening more than X amount of months can have an impact on the graft outcome?
I mean, sir, the HD vintage with the correlation of DSA, sir, that's kind of.
HD vintage and the graft survival.
Sir, I don't know, sir.
So it's been seen that 6 months, the patients, if they have a transplant within 6 months of starting dialysis, have a better outcome as compared to those who have a dialysis vintage of more than 6 months. So that is, the earlier you do a transplant, the better it is.
EMT is also better. Yes.
So this patient, if you were the treating nephrologist and he comes to you and you were counseling him about transplant, why would you say that he should go for a transplant as compared to staying in dialysis?
The one thing there will be a mortality benefit, sir, because even with the highest standards of dialysis, and if we do transplant in the patients getting highest standard of dialysis, there is mortality benefit.
You'll have to give some numbers. You see, for him to understand what is the benefit, just saying that no, this is better, this is not very this thing. So you have to give him certain figures by which he can get convinced that he should go for a transplant.
5-year hemodialysis mortality rate is around.
Yes, survival. We talk in terms of survival. 5-year survival on hemodialysis is
around 50 to 60%, sir.
good?
70%, sir. 5-year survival with.
So that's very high. Okay. So generally, the 5-year survival in non-diabetic is about 40 to 45%. Okay. And in a transplant, what is the survival, graft survival these days? What are the figures?
Transplant in living donor has some, sir, 65 to 75% at least 5-year graft survival living donor.
When you talk in terms of 1 year, 5 years, and 10 years.
10 years, sir, 1 year graft survival will be around 90%. 95%, sir. 95%, sir.
It's 90, now it's even higher, 98% actually, with improvement in surgical techniques and immunosuppressants. So it is as high as 98%, 95 to 98%. And say 5-year survival is around?
5-year survival is around 80%, 80 to 85%, and
5 to 80%. And what is something known as graft half-life? We talk about, have you heard of this term, graft half-life?
So graft half-life is the number of grafts, the time at which half of the grafts will be still working, which were functioning at 1 year.
Okay. So 50% of the grafts will be functioning, and so what is the average graft half-life now?
Living donors, sir, graft half-life will be, sir, 12 to 15 years. 15 years, sir.
It's 15 years.
15 years.
Graft half-life is about 15 years. Okay. Okay. Very good. Okay. So now you said that this gentleman his mother-in-law donated a kidney. So when you are assessing somebody as a potential donor, what are the tests that you will do to make sure that the kidney does not get rejected at the time of transplantation, or the kidney is likely to work for some length of time?
So the
What are the various
clinical workup that we do in living donor is one is, sir, we do the HLA typing, and then we do cross match. Cross match we do cell-dependent, complement-dependent cytotoxic cross match, CDC cross match.
So let's talk about the HLA matching.
Yes, sir.
We're talking about HLA matching. So how does HLA matching impact?
HLA matching, we have to think, sir, if there are unacceptable mismatched HLA in the loci that we have to match, like we usually match A, B, C, and DP, DQ, DR. These 12 positions we match, and we have to see how much mismatch is there, and which one of them are probably going to have some unacceptable outcomes for that. So the higher the match, the better the outcome will be, and the more the mismatch, the worse the outcome will be. And this HLA matching goes beyond the effect of immune suppression. It's not like we have mismatched HLA and we are giving intensified immunosuppression, and the graft function will be.
But have you looked at the data from Opel's registry?
Opel registry.
Opel's. Have you heard of the person called Opel? He's no more. But so he had done a lot of work on HLA and cross-match. So in HLA, he had a registry where he looked at the various donors. He looked at spousal donors, then he looked at those with 50% match, those with identical twin. So what was the results of his registry? Any idea?
I don't remember, sir.
So what you were saying theoretically is correct, that the better they match, the greater, longer likelihood and better survival of the kidney. But Opel's registry actually surprisingly showed that spousal donors are usually zero match,
Yes.
had a better outcome, long-term outcome. And so that was a little strange, because everybody was saying that you must do HLA to find out that the HLA compatibility obviously would have an impact. So Opel's data was a little different, and they showed that the spousal donors actually, then they said it could be because of emotional things. So the explanation was not, of course, very well accepted, but that was the data. Okay. So you said one was HLA typing you do. And amongst the HLA typing, you mentioned a whole lot of things. So which are the important ones nowadays that people are looking at?
Sir, A, B, and DR are the most important.
What about DQ?
DQ is important. DQ is also very important, but DP has a bit less importance. We can give to.
So the HLA could be classified as class 1, and then there's class 2. Is that right? So what is class 1 and what is class 2?
Class 1 is, sir, HLA A, B, and C.
Right.
2 is, sir, DP, DQ, and DR.
Okay. Okay. So then you look at that, and this is important if you are specifically particularly in those who are going in for a second transplant. There you must look at the extent of DQ mismatch, because that would play an important role, particularly in those who are going in for a second transplant or those who are sensitive.
Sensitized.
So what are the other tests besides HLA?
So cross match we can do.
Okay.
That is CDC cross match and flow cross match. And also PSA we can donor specific antibody we can test by single antigen bead method. So in this patient, the mother-in-law is the donor.
what are the things that you would have done? You would have done, one is the CDC cross-match, obviously, that is complement dependent cytotoxic cross-match. And so that is the basic thing. Then what other things? What are the...
So one approach we can take, like for one is doing a flow cross-match and a anti-HL antibody screening that we can do. And if neither of them is positive, we can proceed with the transplant. If it's like and if it's like either of them is positive, then we can go with high resolution HLA typing and DSA also.
So this flow cross-match that you talked about, what is this?
Flow cross-match is a cross-match. It's a binding assay, sir. It's a binding assay in which a flow cytometer is used, and and the recipient sera is mixed with the donor cell, and then we tag them with a anti-human IgG.
I don't want to go into the technique, that will be insane. So it helps you to identify what? Why just not CDC? I mean, if your CDC is negative, why do you need to go to flow cytometry?
CDC has a high inter-observer variability, and CDC doesn't always identify the low avidity antibody. It doesn't always identify, and the reproducibility and the result of flow cross-match.
So flow cross-match will pick up which type of antibodies or antigens that you may have missed out on CDC?
Like not if the antibody is not complement fixing, the CDC will not recognize them, but flow will also recognize those antibodies. And
so if your CDC is negative and flow is positive,
yes, sir,
can we do a transplant?
If CDC is negative, flow is positive, then we have to see we can see the SAB, sir, how much the MFI is of that antibody which is binding with the donor cell. And if the MFI of the mean fluorescence intensity is too high, we can go not for the transplant, or we can opt for desensitization.
Okay, because it is said that the flow can pick up non-HLA antibodies.
Yes, sir.
And so they may or may not be important. And so in that situation, as you said, you can the Luminex method, and you can look at the single test, and you can look at the preformed donor-specific antibodies. Is there any importance of doing PRA?
Yes, sir. PRA helps us specifically to see the virtual calculated PRA that helps us to do a virtual cross-match and see how much sensitized the patient is. So if you want to enlist the patient for the deceased donor enlistment, what is the possibility or probability of him getting a kidney? It helps us in allocation, and the patient.
It is not really very beneficial in a patient like ours,
Yes,
like the index patient who's going in for the first transplant. It would be helpful in patients who are going in for a second transplant or highly sensitized patient. Now, you mentioned that this patient was started on immunosuppression, mycophenolate mofetil, tacrolimus, and steroids. Why did they choose this particular combination?
this particular combination.
That this is the best combination.
So there was this study, like Elite Symphony study, in which they showed that this low-dose tacrolimus, mycophenolate mofetil, and steroid has they have the lowest rate of biopsy-proven acute rejection, and in terms of EGFR at 12 months, it was also.
So the tacrolimus that you start, generally, what is the dose of tacrolimus that you would start? You said low-dose tacrolimus. What is the dose? When you write the prescription.
0.01 milligram per kg.
Sorry?
0.1, sorry, sir. 0.1 milligram per kg, sir. 0.1 milligram per kg.
So 0.1 milligram. So do pediatric patients require lesser dose of tacrolimus or higher dose? Or same dose as adults?
Sir, actually, pediatric patients require higher dose and short interval between dosage in terms of.
So in pediatric patients, what is the dose that is recommended? It's 0.2.
0.2.
Okay. So you require higher dose because they are more immunogenic. Okay. And you said the induction agent, you are not aware. So what is the usefulness of using an induction agent? And what are the induction agents that you are aware of?
Sir, induction agents can be depleting or non-depleting.
Right.
Depleting, it can be, in non-depleting, it can be rituximab or basiliximab. In depleting, it can be monoclonal or polyclonal. In monoclonal, it can be alemtuzumab, or in polyclonal, it can be ATG, anti-thymocyte globulin, rabbit or equine.
So how do you decide which induction agent to choose? Like in this patient, which induction agent would you have chosen?
Usually in low risk, low immunological risk patients, we usually use basiliximab, sir. And
What are the low risk patients?
the patients who are not sensitized, having a haplomatched kidney, or no history of sensitization, then we will give, or it's a living donor kidney. Living related transplant, we will go for basiliximab more or less. But in high risk deceased donor, unrelated transplants, or even DCD, we will use ATG most of the time, sir.
What are the other high risk groups?
Second transplant, retransplant groups.
Okay, very good. What else? Blood transfusions?
Yes, sir. Sensitized patients like
Multiple blood transfusions. What else?
retransplantation.
What else? Multiple pregnancies?
Yes, sir. I told sir, pregnancy, blood transfusion, and retransplant. These are most sensitized. And sir,
Anything to do in the spousal group? Anything? In the spousal transplant, wife to husband, husband to wife, which one is more?
ATG, ATG we can use in spousal.
Suppose somebody, husband is donating to wife,
Yes, sir.
or wife is donating to husband. Which one is more sensitive?
Husband to wife, sir, is more immunogenic.
Yeah. So husband to wife is high risk again. So there you're likely to use ATG. Of course, it has been seen that in the African population, again, they are considered to be high risk population. So in this patient, which one would you have chosen? You've chosen polyclonal or a monoclonal induction agent?
So the patient can't remember, but according to our institution, probably sir, it was
which one you would have chosen? I'm asking you.
ATG, sir, anti-thymocyte globulin, sir.
Why?
Because the one point, so the patient had history of blood transfusion, so probably the patient was sensitized. Another is an unrelated transplant, sir. So probably it will be a high risk. There will be a high risk of acute rejection. Antibody mediated rejection will be more. So I will try to use RATG, rapid ATG. So there will be the DSA production can be suppressed.
Benefit of using an induction agent.
Yes, sir. The benefit of using induction agents, sir, the acute rejection episodes will be less. DGF, delayed graft function, will be less. And
so why are we so concerned about acute rejections being less? See, rejection can happen any time after the transplant. It's not necessarily that it will, and these induction agent will not have its impact throughout the life of the patient. It will, how much time does the induction agent really have its benefit? What length of time?
So 3 to 6 months.
6 months.
I'm not sure, sir.
Okay. Generally, about in the first 1 to 3 months is the maximum period, usually 1 month. So if a rejection happens during the first 1 month, as compared to somebody having a rejection after 3 years, what is the difference?
So some studies have shown that episodes of acute rejection in early time post transplant that will hamper the longer graft function.
Absolutely correct. So rejections happening early in the course of the transplant have a impact on the graft survival.
Yes.
Okay. But are easier to treat. those rejections which happen later do not have so much impact on the graft outcome, but are more difficult to treat. Okay, they're less responsive to treatment. So this patient you said had good urine output for 3 days, and thereafter he suddenly dropped his urine output, and then he developed edema, his creatinine went up, he required dialysis, and then he was given some special dialysis with some yellow colored fluid and some other medicines in glass bottles, you said. Undergoing a biopsy. So do you think the biopsy which was done on day 12, his urine output had dropped after 3 days?
Yes, sir.
Done earlier?
Yes, sir. It should have been done earlier, but in the context of low platelet and low hemoglobin, so probably it was considered as a high risk biopsy, and probably that was so that's why the biopsy was delayed, I think, and he was managed with some readjustment of medication dose, supportive therapy by hemodialysis.
Suppose in a situation where you are not able to do a biopsy, yet the patient has had a graft dysfunction. What are the other non-invasive methods that you can utilize to confirm your suspicion?
So we can use biomarkers like one is DSA, sir. We can use if the DSA has increased,
Very
that
good.
point us towards rejection. There are also other novel biomarkers like cell-free DNA, TIM3, CXCL9, CXCX10, those things.
These are the newer biomarkers.
FOXP3, those biomarkers we can use. And
May or may not be available at all centers. What
yes,
are things that are available within at the moment?
so we can look at the drug trough concentration to rule out the other things. And actually, sir, in our institution, we give a steroid boost if other things are more or less excluded.
The institution does. I'm just asking what are the various investigations.
Okay.
Can we do a Doppler ultrasound? Does it help?
Yes, yes, sir. Doppler ultrasound can help also in terms of.
So what does Doppler ultrasound show?
Doppler ultrasound, for first thing, sir, it helps us exclude the other things. That is, if there is any hydronephrosis or any collection around it, or if there is any renal venous thrombosis or arterial thrombosis.
Doppler is mostly for the vascular thing. Doppler is not so much for hydronephrosis. That is the routine ultrasound.
USG.
So Doppler is for vascular this thing, abnormality. So if your blood flows are okay or not, because that could be one renal artery, the transplant artery vessel could be affected, which because of which the urine output has dropped, or as you said, the venous thrombosis, or there could be some intragraft. You look at something known as resistivity index.
Resistive index we can look at. There is also a study regarding that, regarding ATN versus acute rejection, where they calculated the RI and they showed that it was around 0.7 in acute rejection.
So anything above 0.7 is suggestive, could be an acute rejection, or could even sometimes an ATN also could be there.
Yes.
So if you are not able to do a biopsy should be done as early as possible, because that is the thing. And if you have had a low platelets, maybe you should try and improve the platelet count with some platelet transfusion, etc. Single, if it is required. And you should also investigate why the platelet counts are gone down. Why do you think the platelets go down?
Platelets can go down. One thing is due to decreased production from the bone marrow. Another is more consumption in a.
So in this situation, a transplant patient, what could be the one things that could look platelet counts can go down?
So one thing is post-transplant thrombotic microangiopathy, where it can go down, and also the drug-induced like ATG, mycophenolate mofetil, those decrease the production.
Drugs, the ATG particularly can also reduce both the white cell count as well as sometimes the platelets can also go down. But then you must suspect, as you said rightly, the thrombotic microangiopathy. It can happen because of
thrombotic so CNI mTOR inhibitor. Those things. Also, acute rejection can cause thrombotic microangiopathy.
Also present as TMAs. Okay, very good. Okay. Now, which type of, see, you were suspecting your first possibility, you said in your diagnosis, was that it is possibly an acute rejection. And you said that my first possibility is an acute antibody-mediated rejection. Why did you think of that?
Sir, one thing, the patient was sensitized by blood transfusion and it was an unrelated transplant. So the risk of rejection was always higher in this patient. And this patient had initially he has good urine output. After that, it dropped, which was managed by plasma exchange, probably the special forms of dialysis, which he was.
So I think before you start the plasma exchange, I mean, if suppose you were the treating doctor,
Sir,
I'm things become different. But if you were at that time the treating doctor, at 3 days you drop in urine output, platelet counts had dropped. So what thought would have come to your mind at that point of time? Would you have thought that it could be a T cell mediated or a antibody mediated?
Sir, actually, the first thing when the urine output drops, other things we have to exclude. That should I say, sir? Like catheter blockage, ATN.
So that those things you have excluded. That's fine. That's fine. You're now talking about rejection.
Such cell mediated, we can think of cell mediated, but in this era of triple immune suppression, it's a bit in the lower.
So if you have a rejection which is fairly early,
Yes, sir.
within the first 48 to 72 hours, so then it is more likely to be an antibody-mediated rejection. You could still have a mixed rejection, which could be a combination of both cell-mediated as T-cell-mediated as well as an antibody-mediated rejection. But antibody mediation would be a little higher in the cards, like you thought yourself. Okay. Can you hear me?
Yes, sir. Yes, sir.
So, so we have an antibody-mediated rejection. How does it differ from a T-cell-mediated rejection in terms of pathophysiology or in terms of treatment?
Sir, in terms of pathophysiology, T-cell mediated rejection mainly occurs by the direct pathway in which the recipient T-cell recognizes the donor antigen presented by donor APC. And the effector pathway by CD8 mainly, CD8 positive T cells only. And when these T cells get activated, they are attracted to different parts of allograft and mediates the damage. In terms of AVMR, if there is already a preformed antibody, due to memory response, the antibody production will increase, and the thing is, the presentation will be indirect more or less by CD4 positive cells. They will interact with the donor antigen, which is presented by recipient APC. Also, there is also a pathway called semi-direct pathway, sir, in which there is an interchange of antigen molecule between donor cells and donor APC and recipient APC by either trogocytosis or
role of NK cells. Have you read about NK cells?
NK cells. NK cells, they actually are in antibody-mediated rejections, or sometimes they can have innate allo recognition. They can identify the non-self or the absence of their own HLA in that donor kidney graft, donor graft, and they can mediate the damage. NK cells are more refractory to, they carries a worse prognosis in rejection. If we get
and they have looked at, now people are looking at genetic studies, which can see whether any particular genetic patients are more prone to develop these antibody-mediated rejections. Fine. And in terms of treatment and outcome, how do you manage patients with antibody-mediated rejections?
Sir, antibody-mediated rejection patients, we usually see if the patient has undergone transplant less than 1 year. So then we go for Plex. We always give bolus dose of glucocorticoids, 500 milligram of methylprednisolone per day for 3 to 5 doses. And
but does it have a role in giving steroids in antibody-mediated rejection? Does it have any benefit?
Sir, So probably it will have some benefits.
The standard protocol for treatment of, say, ABMR does not include steroids, does it?
Pulse steroid we usually give, sir, but
That we give because it may be that you're not sure what type of rejection it is, and you presume that it could be a T-cell mediated rejection. But does the standard protocol for a treatment of ABMR include steroids, or is it? So essentially, you gave what? You said plasmapheresis plex you did. What else?
Plasmapheresis to remove that antibody from the body.
Remove antibodies. And then what else do you do?
IVIG. IVIG we can give IV immunoglobulin.
Why do you give IVIG?
IVIG can neutralize the antibodies and cytokines. It can also inhibit the formation of immune complex. It can inhibit the complement activation. It will also make FC mediated.
How much IVIG do you give, and how many sessions of plasmapheresis should we do?
5 to 7 sessions of plasmapheresis with 40 to 60 ml per kg of plasma, and sir, we can replace the fluid by FFP or albumin, and after each plasmapheresis session we can give low dose IVIG like 100 mg per kg after each session, or we can give high dose IVIG like after all the session 2 gram per kg IVIG to that we can build.
Right. So now, what is the pathology? If you looked at the histology of a patient after you've done a biopsy, this fellow had a biopsy on day 12. What would be the pathological markers that would suggest this patient had ABMR?
Sir, the patient will have microvascular inflammation. That is, there will be present of inflammation in the glomerular capillaries, glomerulitis, and other capillary in the peritubular part. That peritubular capillaritis will also be there, and we can also have subendothelial swelling or endothelial widening. TMA-like picture we can also have, and we can also have acute tubular injury.
So you will have features of thrombotic microangiopathy.
Yes, sir.
Then what else would you have?
Acute tubular injury we can have.
Right.
And also in IF we will get C4D deposition in the capillaries.
So is that a must, C4D, or can you have a C4D negative ABMR also?
Yes, sir. C4D negative ABMR we can also have.
So go ahead, tell me.
Sir, according to criteria, we'll have to fulfill all the 3 criteria to stamp it as ABMR, like the histological evidence of injury, then the antigen antibody interaction with the endothelium in the form of G plus PTC or C4D, and last we can have a serological evidence of DSA or C4D. So if the C4D is also negative, then can we also tell that as ABMR with the help of genetic test, molecular transcripts and classifiers that we can do also.
Right. So this was the recommendation of which group? This
And
BAM.
yes, sir.
BAM, what was the latest recommendation? Which year was it, the last consensus meeting? Was it 2018, 2019, 2020?
Later, sir. It was 2023, sir, I think. 22.
Okay. I think 2018 was their first recommendation, and then they modified it in 2019 and some new changes in 2020. Okay. Now, you said that there could be a second possibility. You said post-transplant TMA.
Yes, sir. Yes, sir.
So how would you differentiate? Because TMA can happen even with ABMR.
Yes, sir. Sir, the post-transplant TMA can be recurrence of the disease, one thing. Another is de novo TMA that can also occur, and the de novo TMA ABMR is an important cause. So in that ABMR there will be more MBR positivity and DSA positivity that will point us towards AMR related TMA more. In the other causes of TMA, there can be other features of acute. If it's due to CNI toxicity feature we can have.
I'm just saying that if it is TMA alone and not antibody mediation,
yes,
how would you make out?
Sir, there will not be that much microvascular inflammation or C4D positivity in a
But see, investigation-wise, you'll find in TMA some significant decrease in hemoglobin. Okay, drop in hemoglobin, which may not be so much in, say, with antibody-mediated rejection. Secondly, you may not find such a rapid rise in creatinine, which will be more there with antibody-mediated rejection as compared to TMA. There would be some rise, but not so much significant rise. So those are some clinical clues as to whether this is just TMA alone or is it a TMA as part of ABMR. Okay. Now you said third possibility you said was CNI toxicity and recurrence of the disease. Third and fourth possibilities. Why does that come to your mind?
CNI toxicity can give rise to CNI acute TMA-like pictures, sir, in where the CNI level can still be normal, and we can get this capillary, formation of capillaries formed by. Although CNI itself by itself doesn't cause TMA always, it actually is supposed to be and thought to be an exacerbator of previous complement dysregulatory pathway or some other effects where it is precipitating the TMA-like picture.
In this situation, does you think that he fits into more like a CNI toxicity?
I don't think so, because probably they didn't, according to the history, they didn't do the biopsy initially. Some adjustment was done, but still the creatinine was high, and the patient has decreasing urine output, and it only
not have a sort of such a drop in urine output with rapid rise in creatinine is a little less likely, requiring volume, going into volume overload, etc. So that seems to be less. And recurrence of disease, as your first diagnosis of his basic disease was IgA. You think it could have the recurrence so early in the first week?
No, sir. IgA usually recurs much later, although the histological recurrence can occur early, but the clinical recurrence usually
not occur within a week's time.
Still not a week's time.
Which glomerular disease will occur early?
The FSGS, non-genetic FSGS will occur. We can occur very early. The typical
early, the malignant type of FSGS, which can occur fairly early in the course of the disease. Is that right?
Yes, sir.
Okay. So, if at all this is a glomerular disease that would have recurred, would have been FSGS.
Yes, yes.
So, Pratik, are we, is the time up?
Sir, if you want, you can continue.
Oh, we are done, almost done. We are finished. So I think Tatagato has done a good presentation, and only thing that you will have to read up about some trials, because these are, somebody might ask you about some data, which is important. But otherwise, you have done a good presentation. Well done.
My job is to summarize the class and before proceeding to the section, because it is a great class. We are always learning in every time you take any class. So, Tathagato, you have presented a patient, a middle-aged patient who have a non-near related from his mother-in-law donor transplantation with an acute graft dysfunction and probable kidney disease of chronic glomerulonephritis with a dialysis vintage of 2 years. So, he started right from the beginning. As a teacher was asked you what can be the possible etiological diagnosis, although biopsy was not done. And he reminded that it can be FSGS much more commonly because the progression of FSGS is faster compared to the IgA. In 90% cases, IgA has a chronic presentation of us and it progresses very slowly, rather than a presentic one which progresses fast. That happens to only 5 to 10% of the cases. So this can be an FSGS, and that should be kept in mind in any patient who are undergoing transplantation. And then he asked about the access, as the patient was had this is a tunnel venous catheter, how long you can keep and what are the problems, and how do you decide the frequency of the dialysis. This is a very common problem, but we don't usually know the background on which we ask the patient for 1 or 2 or 3 dialysis. We asked about the incremental dialysis and what is the utility of doing this incremental dialysis, and before taking the patient to the whole program, what about the importance of residual renal function? And how do you decide when do you decide the patient needs a dialysis? Because the dialysis practice has changed before 2010 and after 2010. And that is the ideal trial, which suggests that maybe 6 to 7 eGFR, that can be the ideal time for the dialysis. So also in the PD. He has also asked about the importance of keeping a residual renal function by doing a delayed one, and it keeps the metabolic bone disease, anemia management becomes easier, nutrition becomes good, and the middle molecular clearance that is good. So you have to remember that. How do you decide the adequacy of the dialysis other than your mathematics? It can be a history, physical examinations, and also the lab values. You have told that your patient received 3 units of blood transfusion, and he asked what is the importance of, or why do you give importance to blood transfusion, especially when the patient is undergoing transplantation? And if at all you need to do a transplantation, before transplantation, a blood transfusion, what should you do? You can keep a short dose of immunosuppression, or you can give a leukodepleted blood. And why the dialysis vintage is important in a patient, because it has impact on the graft outcome. And about the cutoff, studies says that if you do a transplantation before 6 months, that has a better outcome with the recipients of dialysis. Why he should go for a transplantation? You have to convince every patient before going, because not merely telling a survival is better with a transplantation. He has asked about the graft survival in the present scenario at 1 year, 5 year, and 10 year. That is important thing is a graft half-life. You have to tell the patients the definition of a graft half-life and how does it matter in the life of a transplant patient. He has asked you about the pre-transplant testing to avoid the acute rejections, especially the HLA matching, and what is the importance of HLA matching in live donor. And he reminded you to read the OPEL's registry, which suggests surprisingly the non-blood related or HLA mismatch may have a longer graft outcome. Why? What is important in the HLA in the recent times, especially in the retransplant or sensitized patient? What is the importance of DQ? What is a class 1? What is a class 2? And this is what is the importance in the second transplant about the DQ mismatches or antibodies against the DQ. And other things beside the HLA, what should you do other than CDC is the basic. When should you do the flow cross match? How do you decide why it is important or different from the CDC count, as it detects the non-HLA antibodies, non-complement fixing antibodies, etc. That may have an impact on the future outcome of the graft. He has asked about the PRA. How do you decide PRA? Why it is not that important? Because we don't have any data of the HLA of our populations, when it is more important in a sensitized patient or a retransplantation. You told that your patient received triple immunosuppression. Why this triple immunosuppression? Who decided that? And you exactly pointed about the Symphony trial. He asked about the dosage of the tacrolimus. What is a low dose tacrolimus? Why the pediatric patient requires a higher dosage, and what is the higher dosage? And what is the usefulness? You were told that you are not aware of the induction of your patient. He asked about what is the usefulness of the induction. How do you decide the induction? Who is a low risk patient? Who is a high risk patient? In a retransplant, blood transfusion, or multiple pregnancies at the same time, husband to wife donor, the black populations, they are the high risk patient. In those situations, you need a more strong induction treatment. And this is the benefit of using this induction agent to prevent this acute rejection in the early period. He reminded you about it happens to be in the first 1 to 3 months time. What happens if a rejection occurs in a patient like yours in the first 3 months versus first 3 years? The early rejection, that is easier to treat, but an impact on the long-term graft outcome, rather than if it develops in the later one, it is difficult to treat, but not that high impact on the long-term graft outcome. Do you think that biopsy would have been earlier in these patients? And you rightly pointed out, yes, the platelet count was low, but it reminded you the importance of the Doppler test. You should take help not only to assess the function, but also see the vascularity resistive index that may give you a clue towards the cause of the graft dysfunctions. Why the platelet goes down in a patient of post-transplantation? It may be related to TMA, or in cases in other situations also. Why are you considering this is an antibody mediated rejection? Can T-cell mediated rejection can happen post? If it happens very early and very severe, that is mostly either an antibody mediated rejection or maybe a combination of antibody and cell mediated rejection. Yes, I asked about how the AMR differs from the TCMR in terms of pathophysiology and the treatment, importance of the NK cell more genetic studies to detect these rejections? And what about the treatment? Why do you do plasmapheresis? Why you prescribe for the immunoglobulin? Probably you have not told the right dosage, I think, but it should be given. Pathology in cases of the AMR, how can you differentiate between a de novo TMA versus cases where there is antibody mediated rejection plus TMA, where you can get the blood hemoglobin drop, and that may not, and the rapid progression, that that is rapid progression is not there in cases of the systemic TMA. And what we asked about the BAMF classification regarding the biopsy finding, and what is the latest BAMF classification? What is C4D? Can it be negative for such patients? What is the importance for that? Why are you thinking of the CNI toxicities and the recurrence of the disease? As you were saying, that what is about IgA nephropathy and the recurrence, and the FSGS from the recurrence, and that ends up the thorough analysis of your case and what opportunities has been missed and what could have been done, everything, and that is very practical, and these things will face practical life. So with this, we with this summary, we can conclude before going to the OSCE session. Sir, I request you to please stay on this session. It will take not.
No, I will definitely stay, and I enjoyed this, and the OSCE session is very good. I really enjoyed it.
So Dr. Aniruddha is there. He will be presenting the case. Tathagata, you have to read the whatever will be shown in the slide and try to answer. And after that, there will be a small discussion. Everybody will contribute, so you can also join and give your comments in everyone. So Dr. Aniruddha, please.
I'll start sharing my screen, sir. Good evening, sir. The screen visible?
Yes. Yes, it is visible, but make it full screen.
Yes. Yes. Good evening, Tathagata. I'll be starting the case. So this is your first question. Please go through the question.
45-year-old male, diabetic and hypertensive for more than 20 years, end-stage renal disease for 3 months on maintenance hemodialysis, 3 per week. BMI is 29.5 kg per meter square. Wants kidney transplant, spousal donor, ABO compatible, HLA 1/12 match.
So this is the images of the prospective donor. So on the basis of the image, you can go through the images and please tell what you are seeing.
See the image, that is one investigation, and is written another investigation. That those are important before selecting donor nephrectomy. Just tell what is the picture, what can you see, and read what is the investigation. Two are different.
So on the left hand side, this is a CT angiography of the aorta and renal arteries.
Yes.
It shows there is an probably there is an accessory artery on the right side for the upper lobe, sir, in right sided.
Yes.
And in the left side, sir, there is split renal function. There is 55% left kidney function and 44% right kidney function for the differential eGFR of 46.5 ml per minute and 37.5.
So on the basis of this, these are your first questions. What parameters you would be selecting before which kidney to harvest?
In the view of, as there is accessory artery, accessory vessels in the right side, and the eGFR is also high on the right side, 46, and left is 37. I'll try to get lower one, the lower eGFR one for the harvesting.
Suppose both sides is a single artery, which kidney will you select? Is it small lower GFR or a higher GFR?
The lower GFR kidney should be harvested, sir. Here also the right side has double artery, but I'll still go for the right side as it has got the lower eGFR, because higher eGFR kidney should be left for the donor.
So in most of the situation, we take this left kidney. Okay. So you can read the second question and give.
Does the nature of surgery have any bearing on the site selection and quality of vessels? Yes, sir. It can have.
Yes. So what types of surgery you would tell for a donor nephrectomy? What are the types of surgery you know?
So we can do laparoscopic donor kidney retrieval or open
Yes.
donor kidney retrieval.
And also nowadays,
laparoscopic retrieval, laparoscopic donor retrieval.
yes, open laparoscopic and something more advanced.
Robotic kidney, robot assisted donor kidney retrieval, sir.
So depending upon the surgery nature you are doing, and most of the things we are doing laparoscopy versus open. You are planning to take the right kidney, okay?
Yes, sir.
The things you need to see, and what are the possibilities, advantages, and what are the things to consider.
We have to think about this accessory vessels are present or not, and how the anatomy of the recipient will be. What will be my approach in where to place the graft, and then the possible anastomotic sites in terms of the accessory arteries. It can be difficult sometimes, sir.
What about the veins on the right side kidney and the left side kidney when you are planning for nephrectomy?
So the left renal vein is longer, sir. Left renal vein is longer. So if we take the left kidney, so the anastomosis can give us a bit more room to do the anastomosis.
For right to make it longer, you need to take a cuff of the IVC. But most of the laparoscopic surgery is not possible.
Yes, sir.
Okay, in open surgery, it is okay, but when we're doing a laparoscopic surgery, you cannot take a IVC cuff, so you'll get a smaller veins. So the chances of vein-related complications will be high. Okay, go to the next slide. Read it.
Underwent ABO-compatible live renal allograft transplantation. Called ischemia time 1.2 hours. Postoperative day 1, the creatinine was 6.3. Urine output was 4.7 liters. Drain output was 300 ml. Postoperative day 3, the creatinine was 3.5. Urine output was 5 liter. Drain output was 200 ml. And postoperative day 5, the creatinine was 3. Urine output 5.1 liter. And drain output was 100 ml. Is the graft function satisfactory? What can be the possible cause? So graft function satisfactory graft function can be defined in the terms of immediate post-transplant. One is urine output, and another is adequate creatinine reduction in terms of 1 to 2 milligram fall per day, or at least 10% reduction minimum. Below that, it will be considered as SGF. And
it's slow. It is a bit
slow graft function. QD5 it's 3, and it's a slow graft function, sir.
So what can be the reason, possible cause? You can see the slide again and tell us.
Yes, sir. One possible cause, because this much high urine output, always in slow graft function, we can look at dehydration. First thing, pre-renal causes of increased creatinine. This much high urine output, is the intake adequately matched or not? That we have to look at. And there can be always a during intra-op medullary hypoxia that can give rise to this type of high urine output.
There is a clue in the slide.
CIT was high. Port ischemia time was high, sir.
Because you have taken two, I have chosen to take 2 arteries, that too from the right side of the small vein. Natural anastomotic time is high.
High, sir. That's why maybe more IRI or injury has occurred. That's why there was medullary hypoxia and this kind of high urine output.
The ATN can expect some amount of tubular necrosis. Next slide. Read it.
Postoperative day 1, creatinine was 6.3, urine output 4.7 liter, drain output 300 ml. Postoperative day 3, creatinine was 3.5, urine output 5 liters, drain output was 200 ml. Postoperative day 5, creatinine was 3, and urine output was 5.1 liter, drain output was 100 ml. Postoperative day 7, creatinine increased to 4, urine output 300 ml, drain output increased to 200 ml. There was complaint of UD 6-7, there was pain in abdomen and surgical site. How will you evaluate the patient? Sir, the creatinine rose after day 5 from 3 to 4, and the urine output also dropped from 5.1 liter to 300 ml. Drain output also increased. So, in terms of evaluation of this sudden drop in urine output, first I will check the catheter if there is any blockage or not. Then I will check the hydration status of the patient, and also I would like to do an ultrasonography with Doppler to rule out any collection, any obstruction, or any vascular events that have occurred in this time. And also I would like to send the drug trough levels, revisit them if they have caused, and then I will try to rule out the rejection by biopsy if possible, sir. And two are, yes.
So you see that what investigation, one of the investigation is provided to you. Next.
The kidney looks enlarged, sir, 12.5 centimeter, and a bit congested. There is no flow in the RV, renal vein, and there is a reversal of the diastolic flow in the renal artery. So this can be a case of renal vein thrombosis. The risk factors will be dehydration, multiple arteries, technical causes, and like in this, sir, and also some thrombophilic, previously thrombophilic condition that was pre-existing, size mismatch, accessory vessels, and immunosuppression. Proteinuria. Proteinuria can also cause from, if there was high proteinuria from the native kidney due to the disease, that can also give rise to post-transplant renal vein thrombosis.
Okay, so anything to do with the age of the patient, in which some subgroups they are more prone to develop this complication?
Elderly persons are
elderly or in other way of the spectrum? In children, in a pediatric transplantation, do you see more? Is there any possibility of more thrombosis in them?
with yes, sir. Children with hypoallergenic.
Why this is so? Because you are putting a big graft of mother or maybe grandmother, and the small vessel, there is sudden stasis of life.
Okay, sir. Size mismatch.
Children, so hydration, maintaining hydration is very important in the post-transplant period. Okay. And, what about this third one? Can immunosuppression play any role?
Yes, sir. CNI calcineurin inhibitors, especially cyclosporine, is known to cause more thrombosis.
Yes. Yes, if it at all happens, is more in the cyclosporine era. So now we'll proceed to manage such.
Sir, in acute renal venous thrombosis, usually the scenario is we have to lose the graft usually. That is the usual thing. But if we can diagnose it pretty early, then we can take the surgical exploration. We can take the patient for surgical exploration. We can see if we can remove that part of the vein, reanastomose it with help of the surgeons, and we may try to salvage the graft. But usually that's the scenario in acute RV. And post-op anticoagulant, I can also use that.
Are you more concerned about the graft or something else?
Actually, the patient has, if the graft rupture can happen, in this case, graft rupture can happen and the patient, we may lose the patient also.
Yes.
Then
So,
the graft. Yes, sir.
so your response should be very smart and prompt. Next. So this procedure has been tried.
What is the nature of the imaging and what is the intervention being attempted?
Endovascular recanalization, endovascular approach to from
All bones have been removed. You can see only the vessels. What is the investigation?
angiography, digital subtraction angiography, DSA.
Yes. Because of that, you need to do for a proper intervention. What intervention is done?
Endovascular thrombolysis or angioplasty, venoplasty, or
Thrombectomy is being done. Okay. For a vein, you can try this. Okay, next. Read it.
Post procedure within 48 hours. BP is blood pressure is 90 by 60 millimeter of mercury. Pulse was 130 per minute. Urine output less than 50 ml. Brain output looks like bloody, sanguineous, serosanguineous, and in CT.
This is the drain and this is the CT scan. CT or a CT angiogram? You can see the vessels. Some vessels you can see and some vessels you cannot see.
Some vessels we can see.
So there is enhancements. It's a contrast study. Okay. But if there is a, you cannot see the vascularity inside the kidney.
Yes, sir.
Next.
Is the diagnosis here?
That is the there is a labeled one hyperdense part around the kidney, convex part of the kidney. Probably that's the hematoma.
Yes. Hematoma as well as you can see the drain.
Yes, sir.
So probably what has happened to such patient? Hemodynamically collapsed.
Yeah, ruptured graft probably that has happened, and that's why the blood is
So
a bit blood around the convex margin.
yes, yes, yes.
Rupture of the graft.
So
The patient underwent a
graft. Okay.
Coming to the question 2 for the same patient.
Okay, sir. After 1 year on maintenance hemodialysis, he was enlisted for cadaveric transplantation. Received a call for deceased donor kidney transplantation. Donor was a 35-year-old female, and cause of death was road traffic accident, intracerebral hemorrhage. Right-sided kidney was harvested. It had 3 arteries. Full ischemia time was 2 hours. Grafted on the left side. POD 0, post-operative day 0, the creatinine was 7.1. Urine output 1.2 liters. POD 1, creatinine was 4.2. Urine output 2.5 liters. And POD post-operative 2, creatinine was 4.5. Urine output was 100 ml.
So how would you your doctor? These are your findings.
This one in the left side is a colored Doppler, and this is a pulse Doppler. You can see that.
No
Can you see any flow inside?
no flow is seen within the kidney, sir.
Okay. Again, the same kind of thing. Okay.
Yes, sir. So probably it's a
And this time,
renal artery thrombosis.
So any investigation you need, because surgeon will not be convinced with the only the blood flow. It's an emergency. Now your threat is towards the kidney only, not the life of the patient. So you can do the investigations.
You can do CT angiography. We can do, sir.
Yes. So go to next.
And if there is any,
Yes.
and the patient is also highly sensitized, sir. So
So that is one important risk factor for any kind of thrombosis.
yes, sir.
Doesn't happen in normal. In accelerated rejection, you will get every time you do the nephrectomy, you get a thrombosis of artery and veins.
Yes, sir.
Go to the next slide. This is on re-exploration the kidney.
Kidney looks pale, sir.
Pale, flabby,
Pale, flabby, and
color. What about the color?
cyanotic bluish color, sir. Pale bluish color, sir. Patchy reddish part are there, but more or less pale.
Okay. If you get that, you should look for the in the OT in the arterial pulsation or the arterial pulsation it is available or not. So what will do next?
The graft is not, if not salvageable, then we have to
Remove the graft.
remove the graft, sir.
Okay, the veins are okay, arteries are not functioning. You can try out with a re-anastomosis, but if still doesn't work, then you have to for a nephrectomy. But in both the situation, in these situations, how do you monitor such patient? This patient underwent a graft nephrectomy on the table because of artery. Next.
The DSA we can do because this patient will be then highly sensitized. Twice.
He is in the ward and he develops some pain in the left lower limb and read.
There is extension of extension of that thrombosis to the iliac artery, sir. That's why the popliteal and ADP pulse got feeble. And we can also see here there is cutoff in the left-sided angiography report. So in the left-sided vessels, sir. So possible extension of that thrombosis can occur.
Yes, you can go back 2 slides where the anastomosis details was given. You can see this is a 3 arteries, then you read 2 letters are written.
Yes, sir. 3 arteries were there.
What is the pantaloon and what is EIA?
EIA is, sir, external iliac artery.
Yes, this anastomosis is the external iliac artery. The multiple artery, that's why a pantaloon has been done. So, the external iliac artery, what is the risk if the patient is anastomosed in the external iliac artery?
If it's anastomosed, the thrombus can extend to that iliac through the end-to-side anastomosis is usually done, sir.
Very cautious because patient may develop a limb ischemia. Okay, probably the patient has developed that. Go to next slide. Yes. Now he will tell what should be done in such situation is very short.
Again, as you said, whenever we have an acute oliguria, anuria, and an immediate post-renal transplant period, primarily we have to check the hemodynamic stability to rule out any kind of hemorrhage, and the immediate modality of choice of image would be a ultrasound to rule out any vascular problem versus any urological problem. Both the cases we discussed here were from vascular aspects, whether it's a transplant renal artery thrombosis or a renal vein thrombosis. Both could be diagnosed early with the presence of with the use of an ultrasound, and as per the diagnosis, we can proceed with the further state of management. Now, these slides, we simply summarize the most common presentations for renal artery thrombosis. The most important thing to note is usually in renal artery thrombosis, the presentation is mainly silent, whereas in comparison to renal venous thrombosis, where the patient would present with painful swelling of the graft, and the renal artery thrombosis can present in a very catastrophic way, the most common risk factors would be presence of any kind of iatrogenic arterial injuries or presence of any kind of difficulty in the anastomosis. If there is present, if the patient has any prothrombotic state or hypercoagulability factors, and also malposition and torsion of the arteries can be a inciting cause. And subsequently, again, the diagnostic imaging of choice can be a contrast CT, but usually a transplant ultrasound can help us in diagnosing. And the most and the it has to be managed with urgent surgical exploration, where we have to open it up, and for arterial thrombosis, we have to try to salvage the thing. But most of the times, salvaging becomes very difficult because the kidneys are very sensitive to even 30-35 minutes of warm ischemia, and after that usually salvage is not possible. So commonly it results in graft nephrectomy. And coming to transplant vein thrombosis, so usually the transplant vein thrombosis can occur a slightly delayed fashion, and usually presents with reduction in urine output or presence of hematuria and presence of pain. The most common risk factors can be collection around the graft, or like hematoma, lymphocytes, or urinoma causing any compression, any iatrogenic venous injuries, or any presence of hypercoagulability factors like previous thrombophilic factors. And the diagnosis is done through ultrasounds, can be confirmed by using contrast CT. And in case of renal venous thrombosis, the salvage can be attempted by open exploration and reduction and open thrombectomy, as well as endovascular interventions. But again, the success is variable, can also commonly can result in graft nephrectomy. Now we come back to the question number 3 for the same patient.
After another 2.5 years of maintenance hemodialysis, the patient wanted to undergo third kidney transplant. Prospective donor was stepsister. HLA match was 2/12.
Okay, so this is the CDC cross-match report.
Yes, and in CDC cross-match, we are seeing T lymphocyte is average cell lysis of 100%, interpreted as strong positive. B lymphocyte CDC is also strongly positive. Flow cytometric cross-match also showed T cell cross-match is positive and B cell cross-match is positive.
So what are the options available for?
What are the options available for this patient? We can do, if the flow is positive and the CDC is positive, it's according to the algorithm, it's better not to desensitize the patient, because in CDC positive patients, desensitization does not lead to that much good outcome. Rather, we can go for a paired donor or alternate donor, or if we don't have any other options left, then we can think about desensitization. And we have to also do a DSA and see what is the MFI of the patient, and then we can follow a desensitization protocol with the help of plasma exchange, IVIG and rituximab. Then we can go for the transplant. And we have to see after desensitization
Next.
if the cross-match has gone negative.
Yes. See the next slide.
Okay, so coming to the patient who is not willing for a swab donation and they do not want to wait for a cadaveric donation. So then how will you be proceeding, as you were describing, for a desensitization?
You can, yes.
This is the high resolution HLA reporting with the prospective donor.
So you can see there are multiple mismatches that was highlighted here. It is on HLA-B, DRB1 and DPB1.
Want to see the next DSA report.
The MFI was very high, it was more than 10,000 for DRB1, at around 10,000 for the other loci of DRB1.
You can see both are present in the donor.
Yes, DRB1 0912 Yes, they're present in the donor. So the options we have here, we may opt for novel desensitizing methods. If we really have to go for transplant.
So they underwent a desensitization here.
Okay.
So we underwent a routine desensitization with rituximab, plasmapheresis, and IVIG, and the cross match is still positive. So what next can you do?
We can give imlifidase and try if a single dose of imlifidase. We can give it's an endopeptides, IgG endopeptides that cleaves the antibodies. Yes.
So you were correctly saying the drug to be used in this setting is imlifidase. So what is the source of imlifidase?
Streptococcus.
Which species? You can specify.
I can't remember.
Streptococcus pyogenes.
Pyogenes.
Next.
So he underwent desensitization using imlifidase, and now we look at the DSAs. The titers are given here.
The titer has definitely decreased. They are on 9.1 and 12.02. They have decreased from around 10,000 to 3,000.
So with this titers, you proceeded with the transplantation, and the
mechanism of action of this agent is immunoglobulin G endopeptidase that the FAB, the FC activity was not there, and FAB activity was preserved. It cleaves the antibody, the DSA to be precise, brings down the MFI of the patient so that the patient becomes less desensitized, and we have to give a single dose of it, 0.25 milligram per kg, single dose. We can repeat it if we still are not able to achieve the negative cross match. The thing is, we have to be cautious about rebound because as the patient had CTC, probably in the studies also they all had rebound.
Question is, will you use the induction treatment?
Induction. This is a high risk transplant, so sir, ATG will be better. So
imlifidase is a non-specific antibody cleaving immunoglobulin cleaving agent, or is a specific one?
IgG is specific. It does.
So if you use this ATG, then what will happen? It will cleave that also.
when would you and how would you use the induction agents?
After some time, we'll give it to.
Will the patient require any induction agent or will not require any induction agent?
Yes, we should give an induction agent because that can help us prevent the rebound of DSA. We can give.
Usually don't give induction on time because it will cleave that. If you need to at all give, then go to the next slide.
Okay. Subsequently, on post-operative day 10.
A few issues are there. One is the induction, another if there is some amount of rejection develops post-operative, then what will you do?
We look at the titers and we look at the serial creatinines.
Post-operative day 0 creatinine was 5.1, post-operative day 5 it was 2.1, and post-operative day 10 it was 1.2. And MFI at post-operative day 10 has also increased from 3,000 to 6,000. Those two DRB1 loci. So
the same report in a different setting is when you have seen the post-operative day 10 serum creatinine instead of 1.2 is 4.2.
Yes.
So what would be the difference in the approach in both these settings? And in which setting you would advise for a biopsy?
The thing is, in here there is increase in DSA along with graft dysfunction. So in this setting, it will be prudent to go for biopsy, and if we get antibody-mediated rejection, which we will probably get in this setting, we can treat accordingly. And but in the setting where there is no graft dysfunction, but still the DSA is rising, it can still predict the development of ABMR, and the thing we
Not
can.
like your case, you cannot give an anti-rejection treatment straight away because those are antibodies, IVIG, you cannot use.
Yes.
Be very sure before starting a treatment.
Yes, sir. But the increase in DSA can herald the development of ABMR in those persons, but we will not advise any suppressive therapy based on DSA.
So you have to know some bits of this new drug because it is coming in the market, and probably it will be very much beneficial and useful for this kind of patients with a very high PRA and sensitized patients. Okay, then Anirudh will tell some few practical details of using this drug.
This was the biopsy which showed ABMR. So how will you manage the ABMR? We'll be talking about. So the mechanism of action, as Dr. Tathagata correctly said, was cleaving the antibody specific for immunoglobulin G and cleaves in the hinge region. And initially, it's a two-step cleaving. It cleaves one of the arms very fast, and subsequently there is a delayed cleaving of the second arm. And step by step, the initial after the initial cleaving, that is the single cleaved immunoglobulins have persistent antigen-dependent cytotoxicity. But once it's completely cleaved, there is no CDC as well as no antigen-dependent cytotoxicity present. And apart from cleaving the antibodies, it also cleaves the B cell receptors, and it reduces the anti-HLA immunoglobulins, and this actually helps in reduction of the immunogenicity and gives you a window for providing an HLA incompatible transplantation. So the consensus guidelines mainly have recommended using this drug only for patients who have very high CPRA or who are very highly sensitized, who are less than 65 years of age, so that we have a possibility of a good graft function and age does not go against it, and usually who have spent more than 3 years on the waiting list. Usually for considering sensitized patient, more than around 0 to 2 transplantations. After more than 2 transplantation, the consensus is still not available. And for patients usually who are mainly very sensitized, initial step before using this imlifidase would be to delist the unacceptable antigens, and then they have to try and see if they can broaden and arrange for any kind of a donor. And mainly the patients who are elderly, who have possibility of poor graft function or who are expanded donors, they are usually avoided when we are using imlifidase. And always, after using imlifidase, after 4 to 6 hours of infusion, a CDC crossmatch has to be repeated, and only if the crossmatch is negative, then we can proceed for a transplantation. So the basic protocol for using imlifidase after an initial induction of rituximab, after 2 weeks, you give the imlifidase, check if the crossmatch is negative, and as sir was saying, as it can cleave all the antibodies, so simultaneous application or use of induction agents are avoided. Usually, the induction agents like rabbit ATGs, which are more efficacious, usually are used after 4 days or the day 4 of transplantation. And after that, IVIG is started to use, because IVIG has a bidirectional relationship when you are using it with imlifidase, because IVIG can actually partly inactivate also, and itself gets cleaved partly. So usually a gap of around 12 hours at least is advised, and normally around 5 to 7 days during this period IVIG is given. And after day 7, a second dose of rituximab is also given. If the patient is given rituximab immediately prior to the transplantation, then the crossmatch has to be checked with anti-rituximab antibodies also. And when we are using imlifidase for a transplantation, serial DSA monitoring is mandatory. So this table shows the timeline when the drugs can be used when you are concurrently using imlifidase. Interesting thing to note is that the equine antithymocyte globulins, that is AntGAM, is resistant, as well as eculizumab is resistant to imlifidase, so they can be given simultaneously. And apart from all the discussions we had, whenever we are having a antibody mediated rejection in patients, because there is always a rebound of immunoglobulins after the initial action of imlifidase is gone away. So this rebound is managed as per the graft function. If there is suspicion of decreasing graft function, then the patient undergoes renal biopsy, and if you get an antibody mediated rejection, it is treated as per the local protocol or the protocol of the center. That it's usually an extracorporeal therapy like plasmapheresis as well as IVIG is given. So
Last question, you just read.
Next 1 year, he is maintaining baseline creatinine 1.5 to 1.6 milligram per DL. He complains of development of intermittent episodes of diarrhea. At 12 months on tacrolimus 1.5 milligram BD, MMF 500 milligram BD, prednisolone 5 milligram once a day. CBC hemoglobin 8.1, total count 3050, neutrophil 80%, lymphocyte 15%, platelet 1.05 thousand. Serum creatinine is 1.58 milligram per DL. Urine routine showed proteinuria stress, RBC 2 to 4 per high power fill, and PASCAL is 3 to 5 high power fill. Albumin is 3.1 gram per DL.
Okay.
WBT0 level is 4.8 nanogram per liter. PK virus is not detected. PRA.
So more or less acceptable. Okay, the next, go to next. But the clinically patient is not very much acceptable.
Over this year, he admitted thrice with complaint of diarrhea and UTI.
these are the skin lesions he has.
Anemia, and here
As well as onychomycosis.
yes.
What do you infer overall?
Those things indicate that the patient had been over immune suppressed. That's why those opportunistic infections has occurred. So there are some novel methods for monitoring the immune status in the patient. Usually we do measure the immune status by only measuring the DSA, or sometimes with EBV viral load or CMV and BK. But now there is this novel method of measuring tortinovirus load that can also predict the immune status of the patient.
Okay.
Let us manage the immune suppression more effectively and efficiently.
So this can tell you what is the actual, whether immunosuppression is going more or this is
Yes.
infection is going more. We have to balance because the patient is prone to both. So here is also some tidbits of using this test nowadays because it is commercially available.
So, basically, as you again described, the conventional markers have been antibodies and monitoring of the drug levels and renal function using urine analysis, serum creatinine, and urine protein, and the net immunosuppression by the clinical features. But other markers which have come up are usually using surveillance biopsies, molecular diagnostics like molecular microarrays, nanostring panels, and tissue genomics. But nowadays, the newer thing has come up, that is the torpotinovirus, which belongs to a family of anelloviruses. And normally, all the healthy persons as well as the solid organ recipients are, since birth, usually they get infected with this virus, which remains embedded. And measurement of the plasma level of these virus titers, which again has become commercially available, can give you an indication whether the patient is over immunosuppressed or under immunosuppressed, and it can act as an immunometer. So it has also been used in fields whenever we are using DMRDs or biologics for autoimmune diseases in patients who are undergoing CAR T cell therapies, as well as in patients during COVID. So if we look at the dynamics of this top rotinovirus blood levels in post-renal transplant patients, normally after an initial dip, the viral copies increase in number by post-operative third month, and after that maintain an equilibrium, and serial measurements can give you an idea. Multiple studies have given multiple levels, but normal consensus is around more than 4.6 log of 10, that is around 10 to the power 6 to 10 to the power 8. If the titers maintain, then there is least risk of rejection as well as infection. Increasing titer of tocotinovirus increase it shows that there is presence of reduced presence of reduced increasing titer represents there is reduction in the immunosuppression, as well as the patient has higher risk of rejections as well. And whenever we are looking at the patient having reducing titers of this tocotinovirus, that shows there is increasing immunity, and the chances of rejection goes up. So it has also been multiple studies have been conducted, and which showed that in cases of ABOI as well as HLA incompatible transplants, the serial titer can corroborate with the risk of BK virus infections, and it can actually highlight the status of the net immunosuppression.
Okay, so with this, we conclude about these OSCE sessions, because these are the things we have discussed which don't commonly read or don't practice much. So specifically the choosing of a donor with a specific kidney, vascular complications, what are the importances, and use of a newer drugs and newer markers that you need to know, because you will be practicing in a world where these tests will be easily and drugs will be easily available. So I think we are slightly running short of time. So this time also we are not doing this presentation on the Organ Transplantation Act. That will be discussed on the next session. So thank you everyone. Thank you, sir.
It was a wonderful OSCE session, and I really enjoyed every bit of it. I learned so much from it. And congratulations to you as well as Aniruddha for putting up this show. Very well.
Thank you, sir. So with this is a long session, we need to close it. Thanks everyone for being with us. Over to Mr. Saurabh.
Thank you, sir. Thank you,
Yeah,
sir.
thank you very much, sir, for giving us the opportunity to be associated with such a wonderful session. And it is always a very, very humbling experience to be present among the iconic figures like Professor Gupta and Dr. Pratik Das, who have been relentlessly trying their level best to elevate the level of knowledge among the young nephrologists. So, and my congratulations to Dr. Tathagata for presenting the cases, and obviously Dr. Aniruddha for the smartest slides that he has presented with a lot of preciseness. Thank you very much, sir. And again, it is we are very, very proud to be associated with this particular program since the inception, since the beginning. So with that, I would like to say good night, thank you, take care, and let us huddle up again with the next classes. Thank you.
Thank you, sir. Thank you, sir. Thank you, sir.
Thank you. Good night.